Hi everyone. This is an addition to your liver and biliary lecture. We're going to talk about problems of the gallbladder and the pancreas. Let's first start with the gallbladder. Let's go back to anatomy and physiology. We can look at some of the problems that the gallbladder has. We'll first start where the gallbladder is located. It's in a little depression right here under the liver. It can hold up to 50 cc's of bile. And some of the problems that we're going to talk about is inflammation of the gallbladder, which is your cholecystitis. If we have gallstones, which is very frequent, cholelithiasis, choledocholithiasis, which is stones in the ducts, and then there's inflammation of the bile duct, which is cholangitis. We're going to talk about all of those different issues. What are the functions of our gallbladder? Again, this is going back to our anatomy and physiology. Our gallbladder collects, concentrates, and stores the bile that our liver has created. As the bile is made, there's water that's reabsorbed and the bile becomes very concentrated. Thus, that's why the gallbladder really only holds the 50 mLs. It's super concentrated, the bile. As we eat and our food goes through our duodenum and signals our gallbladder that we need some aid in digestion, the bile comes down through the common bile duct and is released from the sphincter of Oddi. Our gallbladder will contract, sphincter of Oddi releases and opens up and releases the bile into the duodenum to help in our digestion. Here's just a picture. You can see the gallbladder there, the common bile duct, and right down through the sphincter of Oddi. Let's talk about gallstones. So cholelithiasis. This is a common problem, especially in adults, fifth leading cause of hospitalization for adults. You may have taken care of some patients that have gallstones. Typically, this is a limiting problem for patients. If they don't have an infection, they really have good prognosis. The other word for gallstones is calculi. The stones can be made up of either cholesterol. They can also be pigmented stones, which is a less percentage. But gallstones come from inflammation of our bile duct when decreased bile acid synthesis occurs and then the cholesterol is increased. It results in this supersaturated bile that's saturated with the cholesterol. And cholesterol actually precipitates out and it forms the stones. Gallstones can also be formed from metabolic problems, often pregnancy. Your gallbladder gets a little sluggish during pregnancy. Certain contraceptives can cause it, and also patients with cirrhosis or pancreatitis. It's common with those patients as well. These are just some of a picture of the stones, different color of the stones. The cholesterol stones, which are the most common. It's that imbalance of cholesterol and your bile salts. And then your pigment stones those are mostly associated with your cirrhosis patients. Let's talk about our choledocholithiasis. So this is when you have your gallstones in either the hepatic or your bile ducts. And it causes an obstruction of bile into the duodenum. So what if you think your bilirubins would be increased here? So think about it. We talked in the liver lecture about conjugated and unconjugated bilirubin. So this would raise the patient's conjugated bilirubin because it's already been through the liver, it's been conjugated, but it just can't be released into the body. So your billies are elevated. Your patient can become jaundice, which is the yellowing color of the patient's skin, and they'll have decreased vitamin absorption. Often recovery, again, is good here if there aren't any infection for the patient. Cholecystitis, one of the most common, and 90% of cases come from gallstones here. You can have an acute or chronic inflammation of the gallbladder. So your cystitis is your inflammation. You can have it either with stones or without. So acalculous is the inflammation without the stones. So this is caused from some bile stasis, often patients post-op, patients with sepsis, various traumas, patients that are on TPN, total parenteral nutrition, and also patients that have hypovolemic states can have this type of cholecystitis. Calculus is associated with the gallstones. Typically, gallstones are in the cystic duct. This is the most common, and it causes that bile to be trapped. And think again, the bile is very concentrated, so it's an irritant. This causes painful distension of the gallbladder, can cause ischemia, and then lead to infection. Most patients, or many patients who have gallbladder surgery are due to this chronic inflammation. It is common among the elderly, and again, prognosis is good with the cholecystitis. Chronic cholecystitis is documented repeated episodes of obstruction that cause this chronic inflammation. Your gallbladder from the chronic inflammation can become fibrotic, and then it'll result in the decreased motility. So these patients may have difficulty eating, especially eating fatty foods. You have this backup of bile, which then can cause the pancreatitis or the cholangitis. Jaundice, again, the patient will be jaundiced, so you have the yellow coloring of your skin. Icterus is going to be the yellow coloring of your sclera, and that's most common with the chronic cholecystitis. Pruritus, this is an increase in the bile salts that actually comes out on the patient's skin. I don't know, think about, have you ever had anybody with the increase in bile salts and you can see it on their skin? They're itchy, they need really a lot of lotions and good skin care because their skin becomes very itchy. They have these bile salts that literally come out. It looks like when you sweat and when your sweat dries and you have salty leftover on your skin. That's what this looks like. There's a lot of research that goes into looking, is there a genetic tendency for this chronic cholecystitis? Is it from certain nutritional and lifestyle habits? Do certain families, because of what you eat and your culture, does this contribute? So a lot of research has gone into that. Risk factors for the chronic cholecystitis can obesity, diabetes, dyslipidemia, insulin resistance, and then others as well. So what does it look like when we have cholecystitis? So what are we going to do to diagnose gallbladder issues? Mainly, it's really an extensive history and physical. You want to include the patient's food intake, what precipitated their pain or what precipitates their pain, if it's a frequent pain, how did they get to this place, and what signs can the patient maybe think about? Lab work that you might see, sometimes it's nonspecific with the gallbladder, but if there's an inflammation, you can have an increase in the white count. If there's any liver issues with it, biliary obstruction, especially with stones, you can see some of your liver enzymes increasing, your AST, your ALK-Phos, the LDH, and again, your bilirubins will be increased. Also, to diagnose, you can use ultrasound, which is rapid, it's accurate. Patients that have liver disease, even if you don't want to use dyes or anything like that, ultrasound is a very easy test. It's reproducible, fairly easy for patients to get, 95% accuracy. So that's a common diagnostic test. Some of the other more specific, you can have a HIDA scan. That's a hepatobiliary scan, and it's a nuclear med test where they can visualize the actual gallbladder and look at the patency of the biliary system. Cholangiography, this is using dye, so you have to be careful if you're using this in patients with renal failure because of the contrast. But again, they'll put the dye in and look at the gallbladder system. Oral cholecystography, that's an oral contrast that they can look down through. And these tests can all rule out, if there's other diagnosis, differential diagnoses that need to be made. Management of your gallbladder, you can have non-surgical. So gallbladder is painful. We already spoke about that. So for acute pain, you can use opioids, morphine sulfate. Dilaudid is frequently now used. For a moderate pain, the ketorolac, and then also the ursodiol, which helps to dissolve the stones. It dissolves gallstones in the patients who don't want to have surgery or they can have the surgery. It's a bile acid not naturally produced by the body, and it's stored in the gallbladder. And it decreases the production of cholesterol and helps to dissolve the cholesterol in the bile so that it can't form the stones. So this is a helpful medication. Patients will be put on a diet that avoids fatty foods. And again, as I said, patients typically know what foods trigger them, or they learn that, so they avoid those foods. Patients can also have an ERCP, that's an endoscopic retrograde cholangiopancreatography. So this is a fiber optic scope, goes from the esophagus to the descending duodenum. They look through fluoroscopy and x-ray, and they can look to see if there are any ductal stones. If they see the stones, they can put a little cutting instrument through that scope into the common bile duct, and they can cut or separate out some of the fibers of the sphincter of Oddi, which enlarges the opening and allows stones to pass. So that can be used as diagnostic or treatment. The extracorporeal shock wave lithotripsy, if you think about kidney stones, this is the same type of thing. So they can use that and actually break up the stones so that they're more easily to be passed. Surgical options, you've probably all cared for someone with a lap chole or possibly even an open chole. So the lap chole is less invasive, but there are complications. You can have some bile duct injuries, but that's rare. Recovery is usually quicker with the lap chole because they're not opening the patient. Some of the most discomfort that the patient will have is some abdominal pain. Often patients will say shoulder pain from that gas that's put into the abdomen during the lap chole, but usually it's a quick recovery for these patients. However, if the patient needs an open approach, these are patients that have the severe obstruction, some patients that are obese and need a little bit more exploration. You can have an open approach. Often after the open approach, a Jackson-Pratt drain, JP drain, will be put in the gallbladder bed to prevent the reaccumulation of the fluid. And you expect to be serosanguinish drainage with a little bit of bile. If there's a T-tube, if they explore the common bile duct, a T-tube is placed, and you need to be aware these tubes typically need to be flushed. So you want to be sure that you're aware of your doctor's orders there. Are you flushing these tubes? Typically it's every 8 hours with about 10 mLs of normal saline. You want to keep an eye on the skin around the T-tube because, again, if there's any drainage around the tube, it's irritating to the skin and you want to do good skin care. So that's all I have for the gallbladder. So we're going to move on to the pancreas. And let's talk about pancreatitis. So pancreatitis is the inflammation of the pancreas. This can be serious. It can also be life-threatening. The pancreas secretes enzymes, the pancreatic enzymes that they help in digestion, but these enzymes are pretty nasty. If they back up into the pancreas, they can actually eat away. It's autodigestion, but they can eat away at the pancreas. Pancreatitis can be mild, and patients can get over it easily, or it can be rapidly fatal. NHP, necrotizing hemorrhagic pancreatitis. This is a diffuse bleeding into the pancreatic tissue. It's can be rapidly fatal, so these patients are typically in an ICU. There's acute pancreatitis and also chronic pancreatitis, where over time the pancreatic tissue becomes destroyed. You can have pancreatic ducts that are blocked, and these can cause hypersecretion of those enzymes again, like I said, and they back up into the pancreas and they start to eat away at the tissue. The enzymes that the pancreas has is trypsin, lipase, and elastase. Those are our 3 enzymes. Back to our anatomy and physiology, think about the functions of your pancreas. It's an endocrine function and an exocrine function. So the endocrine function is the secretion of insulin, which we know lowers our blood sugar, secretion of glucagon, which raises our blood sugar, and also somatostatin, which lowers our blood sugar. Our exocrine function is the secretion of the pancreatic enzymes, which help in the digestion. It helps in breakdown of starch, protein, and fat. So our pancreas has the two functions, endocrine and the exocrine. When we're talking about acute pancreatitis, this can be mild or severe. Mild is the inflammation, edema of the pancreas, usually contained within the organ. You can move to severe, which is complete digestion of that gland. As I said, those enzymes are eating away. It can cause necrotic tissue of the pancreas or tissues around the pancreas. It can spread to the retroperitoneal area, causing cysts, abscesses, collection of fluid. These patients are typically, they can be very sick. This occurs often with a history of alcohol abuse, and it causes necrosis. So causes of pancreatitis, you can have blockage of the common bile duct with a stone. We talked about stones previously. You can have an obstruction, which would be a tumor or a possible abscess. Again, long-term alcohol abuse, and this can be undiagnosed until the patient has an acute attack. Some viral infections, Coxsackie virus, the mumps can cause pancreatitis, hyperlipidemia, parathyroidism, often blunt abdominal trauma. You can have penetrating gastric or duodenal ulcers, and then often after surgery that occurs near the pancreas, or patients that have had an ERCP, you can see pancreatitis after that. And then certain toxicities. How does the pancreatitis, how does that look? Often it kind of looks like gallbladder disease. Your pancreas is going to be your left upper quadrant. So obviously this picture, he's holding his wrong side. But severe abdominal pain, it can be mid-epigastric or left upper quadrant. The patient's abdomen will be distended. There may be a mass that you can feel, but often not. They have decreased peristalsis, which is going to cause nausea and vomiting. Sometimes you can look at the patient and they may have Turner sign or Cullen sign, which is that slight ecchymosis. So the Turner sign is the flank, the ecchymosis on the flank. And then the Cullen sign is that ecchymosis around the belly button. And this is from pancreatic enzymes that are in the tissues. As it progresses, the abdomen can become rigid and board-like. That's your peritonitis, which can also then, as it progresses, patient can go into shock, have signs and symptoms of shock, hypotension, tachycardia, and also respiratory distress. How are we going to diagnose our pancreatitis? Again, same as gallbladder, it's a good history and physical. What are the risk factors? What is the history of the patient's pain? How did this progress? When did it start? And give the symptoms. When you look at the lab work for the pancreas, there are 2 fairly specific labs that the patient should have drawn, amylase and a lipase. Now, depending on how long the patient was ill at home before they came in, you may not see a rise in the amylase. The amylase rises early, but it only stays up for a few days. So if you have a patient that has been home sick for a week, you may not see a rise in the amylase. The lipase is a little more specific. It'll rise later, but it lasts a little longer, so that may stay up there. You can have an elevated white count. Again, inflammation, infection, your white count will be up. Hypocalcemia, the calcium will be lower. Fatty acids are released and they actually bind to the ionized calcium, and that decreases the calcium. You can have elevated glucose. Think about the function of your pancreas, which is to decrease your blood sugar with the insulin. So your glucoses may be elevated. Your bilirubins may be elevated. You may have some sugar in the urine. The fibrinogen, C-reactive proteins, will be elevated from inflammation. And then also to diagnose will be x-rays, again, ultrasound, CAT scans to look for cysts or cysts and collections. They'll look at the H&H, complete blood count, to see, has the H&H decreased? Is there any bleeding? They could possibly do a peritoneal fluid sample. That can be looking for amylase in the fluid, looking for pancreatic enzymes and infection. And again, monitoring the patient's stool. Often they're bulky, pale, foul, and fatty. The patient has impaired fat digestion, so the stool will look different than normal. What are we going to do to manage these patients? So basically, we want to relieve their signs and symptoms. So it's mostly symptomatic, trying to decrease inflammation and prevent complications. So the pain is the most common sign and symptom. So in order to do that, we want to decrease the patient's GI activity. If their GI activity is decreased, then their pancreatic activity will be decreased because the enzymes won't be produced. Opioids will be used in severe pain. Again, we talked about morphine, Dilaudid. Patients will be made MPO. Often they'll have an NG tube in, especially if they have abdominal distension, but this will relieve severe nausea and vomiting. If there's biliary obstruction, you would give antiemetics to your patient to help them with the nausea and vomiting. And then also medications to decrease gastric acid secretion, so the ranitidine or omeprazole will be used. Patients, once they are able to eat, enteral feeding is better, and that's what you would want to do when they're able, as they're getting better. TPN, you don't want to use TPN because, again, you're going to have an increase in that glucose, and the patient may also be struggling with being able to manage their glucoses. You're going to correct any fluid or blood loss. If the patient is bleeding, you're going to monitor that with your H&Hs. If the patient has hypovolemia, you want to correct the fluid losses. Antibiotics if there is infection. Insulin if the patient's blood sugars are not able to be corrected. Good respiratory care. You want to monitor for pleural effusions. There may be a stent needed for the patient if pancreatic ducts are blocked. And then if in severe cases, you'll have surgical intervention. So what about after the acute phase, post-acute management? So you'll have, you can give your patient antacids. Acids stimulate the pancreas, so an antacid may help there. Small frequent meals. These patients are nutritionally depleted, so they may need high carbohydrates and high protein for wound healing and to try and help heal that pancreas. Low in fat because the body's having a problem digesting the fat. Definitely no caffeine, no alcohol. You can use ultrasounds to monitor the patient for pseudocysts and abscesses. This is common. Again, those enzymes from the pancreas are very toxic to the patient's peritoneal tissues, so you want to monitor for the cysts and the abscesses. In the elderly patient, mortality is high with pancreatitis, and you have to really watch for other involved organs, anything around and near the pancreas, and aggressively treat any complications that come along. Speaking of complications, we want to monitor our patients for infection of the pancreas. Monitor them for hypovolemia. I talked about that. With the hypovolemia, You'll have the decrease in renal perfusion, which can lead to your acute renal failure. So you're monitoring your patient for hypovolemia. Because of these released vasoactive substances, and you have loss of protein-rich fluid in the retroperitoneum, your patient can become hypovolemic and move to septic shock. So you want to monitor for that. You're monitoring for hemorrhage. There's release of necrotic tissue and enzymes which alter the patient's coagulation. So you want to monitor them for hemorrhage. You want to monitor for the acute renal failure that I spoke about. Also atelectasis, pneumonia, and then moving into ARDS. There are pancreatic enzymes which can leak and go from the peritoneum up into the pleural cavity via the lymph system. So it is a complication of pancreatitis for your patient to have either a pleural effusion or atelectasis. So you have to be aware of that and have that in your mind to think about. DIC, again, because of the alteration in the coagulation. And then diabetes, we spoke about because of the lack of your pancreas functioning properly and the decrease possibly in the insulin production. Chronic pancreatitis, this can develop after repeated acute episodes. Patient, has an acute episode, then they're in remission, and then it may come back again. Often the attacks start to become more frequent, more severe, longer in duration as they occur. You can have chronic calcifying pancreatitis. This you see frequently with patients who have alcohol abuse, where the pancreatic cells actually are replaced from fibrous tissue. And then you can have the chronic obstructive pancreatitis, which is that backflow of the pancreatic secretions. These patients will be very malnourished. They have muscle wasting. They have significant weight loss. They can move into diabetes, again, because of the lack of the pancreas function. And they also have pulmonary complications. And what does chronic pancreatitis look like? It looks the same as the acute, but you'll have, when they have flare-ups, abdominal pain, they can actually have pancreatic ascites. The steatorrhea, we talked about that because there's less fat absorption. Patients are going to lose weight. They're nutritionally depleted. They may appear jaundiced, diabetes, and again, that dark urine. And we manage the chronic almost the same as the acute as far as pain goes. Opioids, other analgesics if needed. These patients can be on long-term pancreatic enzyme replacement therapy to help prevent malnutrition and weight loss. You have to do good patient teaching related to your enzyme administration. So these enzymes should be taken with meals. They should have, followed with a large glass of water. Should not be given with antacids. You want to tell the patient to make sure they're swallowing the tablets or the capsules without chewing them. You can't chew. If the patient isn't able to swallow, they can pierce the gelatin casing on the capsule and place the contents in applesauce. You can't mix the pancreatic enzymes in any protein-containing foods, and they should be careful to wipe their lips after taking the enzymes so that they don't have skin irritation. You're also going to help the patient with their nutritional intake. If they need dietary supplements, what vitamins and minerals do they need, and then teach them about their increased need for calories. And you want to try and prevent recurrence. If surgery is needed, the surgery could be to drain an abscess or a cyst. Often these patients will have drains for a lengthy period of time. The sphincterotomy, we talked about that with an ERCP. They may be able to have that. And then a distal pancreatectomy, where actually they take the head of the pancreas off if it's been necrotic. So those are some of the treatments that you can have with the pancreas. I hope you've found some information there, and if you have any questions, just bring them to class and let me know.